All right, good morning, everyone. Welcome to another Friday morning AMSSM Sports Ultrasound case series. Today we have Dr. Christopher Colvin presenting on distal clavicular osteolysis. He is a sports medicine fellow within the Air Force at Fort Belvoir. He trained in family medicine at Travis Air Force Base in California. He is a CrossFit athlete and he likes to combine some passions of providing medical care and his athletics to give patients confidence to be the fittest versions of themselves. Dr. Colvin, you can get started here.
All right. All right, thank you very much. So like he said, I am Chris Colvin. I am a sports fellow at Fort Belvoir. And today we'll kind of be discussing a shoulder ultrasound and an evaluation of a patient with atraumatic AC joint pain on the right side. I don't have any disclosures. I wish I did. It would be nice, but I don't. All right, today this is what we'll cover. We're going to start off by talking about a case, then we'll review a little bit of anatomy, and then we'll jump right into the ultrasound images, and then we'll briefly discuss the diagnosis today. So today we're going to kind of review some shoulder anatomy, mainly the AC joint. We'll discuss shoulder ultrasound technique, and then we'll kind of discuss and identify some certain pathology on ultrasound. So for our case, we have a 24-year-old male student who presented to the sports medicine clinic with a 2-month history of right shoulder pain with no known trauma or injury. He is a weightlifter and does jiu-jitsu, both of which have become extremely painful for him, but the pain really hasn't interfered with his sleep or his classes at all. But he was recently had to complete a military training in which he was required to perform litter carries, so essentially carrying somebody on a 4-person stretcher, and he had significant pain in the right shoulder with these carries, and he denied any prior shoulder injuries. So on physical exam, it was relatively normal, except for the inability to obtain full shoulder flexion, and testing for his AC joint was grossly positive with positive cross-arm and scarf. And then his shoulder flexion, like I said, was right about 150 degrees. And these are some pictures of his exam and his shoulder. The circles indicate where he has the pain, or where he indicated where the pain was. So his shoulders don't really seem to be extremely asymmetric, but he does have a much more defined posterior musculature than the front. And so he has actually pretty good balance between anterior and posterior muscle bulk. So next, we'll kind of briefly discuss some of the relevant anatomy that we need to know. First, we have the biceps tendon as it courses through that bicipital groove. You can see that right here. Notice how it's in pretty close proximity, if we look on this one over here, to his subscapularis, and then as the supraspinatus and infraspinatus wrap around to the greater tuberosity, those are very close together. And then we can see how the rotator cuff tendons wrap around that humeral head and attach right here at the greater tuberosity and really provide a lot of that stability that brings the shoulder into the glenoid and kind of seats it into that labrum. And then we can see here the complex of ligaments that actually make up that shoulder joint. And we can see this acromial clavicular ligament up here that provides a lot of the stability for the AC joint itself. And then a lot of the ligaments, the coracoacromial and the coracoclavicular ligaments that provide a lot more of that stability for the shoulder itself. And so with ultrasound, we can get quick feedback and confirmation on our clinical suspicion. It's efficient, and then it does require some ongoing skill maintenance. But if we do keep that maintenance of skills up, it becomes rather easy to confirm a diagnosis for us or to allow us to treat. So this protocol is actually taken from our AMSSM website, and it's easily accessible. It is an organized way of examining the main structures of the shoulder. And outside of this protocol, there are other structures that we can examine, but these are the main ones that we'll focus on today. With these, there are three main arm positions that we'll use. A neutral arm with forearm supinated resting on the patient's leg. We'll take a look at most of the anterior structures of the shoulder in that position. And then also the posterior glenohumeral joint and that spinoglenoid notch. We have the CRAS position, so our internal rotation, hand behind the back, mainly looking at the rotator cuff. And we can have our modified CRAS position where we take a look at that rotator interval. So now we'll take a look at the shoulder exam, structure by structure. So in the center of the screen here, we can see the biceps tendon. Circular structure has a little bit of anisotropy with it. And then we can actually follow that down to the pec major tendon as it courses to its attachment on the humerus. We don't show that in this image, but that is something that you can look at. In terms of pathology, you can see biceps tendinosynovitis that will kind of appear as a halo effect around that tendon. And then we can go to our biceps in long axis, and we can see that it has nice fibular structure and courses across the screen in this horizontal line right here. It appears, like I said, with a nice compact fibular structure. Then we come to the subscapularis as it attaches at the left tuberosity. You can see this nice bird beak appearance right in here, and then also shows that nice compact fibular structure. Then as we flip to the short axis, we can see three bundles of tendons, which is normal. And if we were to scan more superiorly, we would actually be able to see the long head of the biceps tendon in short axis, or in long axis as it, in short axis as it turns to course into the joint. With this view, as we saw in this last kind of screen right here, you can externally rotate the shoulder and check for any biceps subluxation. If you do have any suspicion of subcoracoid impingement of that subscapularis, you can actually follow the subscapularis toward the medial part of the body, and you can perform more dynamic movements to check and see if there is any impingement in there. Next, we can move from short axis on the biceps tendon, and we can short axis slide cephalad, and we find ourselves at the AC joint. Here we can look for any osteophytes, joint distension, destruction of that distal clavicle, as we'll talk about in a little bit. But you can see this image right here actually shows fairly normal width of that AC joint. Then we can slide laterally, and we actually see this supraspinatus as it courses under the acromion right in here. And supraspinatus is right here, acromion is up here. And we can ask the patient to abduct the shoulder. We can observe any movement under that acromion, and if there is any bunching or pain with that, we can assess for any signs of impingement with this view. Next, we ask our patient to move into that CRASP position, and we orient the probe on the shoulder, pointing toward that umbilicus, kind of as this diagram up here shows. And we can first look at that supraspinatus as it makes that bird beak over the humerus, and we can see that transition into infraspinatus right under that. And we can then long axis slide, and we can visualize that teres minor as well. Next, we can flip into short axis, and we can actually take a look at the rotator cuff tendons in short axis. And we can assess for any intrasubstance tears, surface fraying, or articular tears that the articular tears may have a little cortical irregularities, and some pain and sonopalpation, pain right over that sonopalpation site. And then we can actually go to the posterior shoulder. So this, we're going to have that patient back in a neutral arm position, and we can evaluate the posterior glenoid. When we evaluate the posterior labrum, we're looking for any degenerative tears. So that labrum sits kind of right in this area right here. And we can actually look at the infraspinatus as it courses over if we have them externally rotate the shoulder to check for any impingement or any bunching of that labrum that could give us some clue as to either degenerative labrum or a small labral tear or posterior impingement. And then we can actually, as we've seen, we can scan over medially into that spinoglenoid notch, and we can assess as the subscapular nerve courses within that groove, and any fluid collection within this groove would be cause for concern of a paralabral cyst, potentially lending more toward a labral pathology. And finally, we get to our rotator interval. We can actually evaluate the superior glenohumeral ligament, that coracohumeral ligament, and then the subscap and supraspinatus tendons. So we have our biceps tendon right in here. We have our coracohumeral ligament on top, and then we have the superior glenohumeral ligament underneath that biceps tendon, forming a little sling, and then we have our rotator cuff tendons on either side. And this is actually an important area in adhesive capsulitis, as this is an area where we have the ability to actually target with certain interventions, such as injections, that can actually provide significant pain relief. So next, we'll actually transition back to our patient now, and we can take a look at his left AC joint, which appears normal. It's on the right side of the screen here. We can see nice kind of square borders of those bones. The yellow arrows here are pointing to that cortex of the distal clavicle. And then we can look at the right side here, and we can actually see subjective widening compared to this left side. And based on this yellow arrow here, we kind of see this degeneration and this destruction of that distal clavicle. These red arrows indicate the widening of that joint. And then here's our ultrasound report. So notice that the biceps tendon, rotator cuff tendons, posterior glenohumeral joint were all normal, but the only abnormality noted was that the right AC joint had widening and that distal clavicle degeneration and destruction. There was also abnormal motion and narrowing of the AC joint with dynamic cross-arm adduction with ultrasound. And we'll see that from the patient's follow-up ultrasound in just a minute. And so we can actually take a look at the right and left compared with their measured distances that were obtained. And again, we see this cortical destruction at the distal clavicle. It's actually almost 3 times the width on the right than it is on the left. And actually, we did get some x-rays of this patient. We see that same widening, but you really can't make out a lot of that destruction that you can on that ultrasound. And so we didn't necessarily need to get these x-rays. They weren't necessarily to confirm a diagnosis, but mainly for a comparison to the ultrasound to show the fairly convincing image that you can see up here with that widening. And then you can see on the left how it's a fairly normal distance. They also, in the radiology read it at about 9 millimeters. And so we can actually see follow-up. Our patient followed up about 2 months afterwards, had made some changes to his activity, but he hadn't really noticed a change in his symptoms, and he continued to have pain. So we can see that it still appears widened, and you can see supraspinatus coursing underneath that joint. And we can see now we're dynamically testing that joint, and we can see how much narrowing there actually is and movement with that cross-arm adduction testing. So he had not been weightlifting and still was having pretty significant pain. So the topic of this case is distal clavicular osteolysis. It's also weightlifter's shoulder. This is a pathologic process involving bony erosions and resorption of that subchondral bone at the distal clavicle. And as we have kind of shown here, ultrasound is very sensitive at picking this up. Just briefly, distal clavicle osteolysis, it's atypical and often repetitive stress to that AC joint, but typically atraumatic, so no big falls or any direct trauma to that area, mainly with those repetitive motions like bench pressing, overhead lifting. And one widely held theory is that it's more microfractures to that subchondral bone and then the body's repeated attempts at repair. It's almost exclusively found in younger athletes. And it used to be thought that it was more males than females. However, with the kind of increase in female weightlifting, we've actually started to see that kind of balance out, and males and females are a little more equal in that regard now. So just a special thanks to Jeff Leggett for sending all of these images, or all of the distal clavicle images, and then for all the mentorship on this presentation. And then I do want to send a shout out to my friend Shane, who helped in obtaining a lot of these images. And so I just wanted to open it up to any questions.
Great work, Chris. Thanks for presenting that. Certainly something that we're going to see, in our sports medicine clinics, especially if you care for young athletes in particular. This is a really easy diagnosis to pick up that, you can avoid some radiation of x-rays and things like that. Just a couple of comments, about the shoulder ultrasound. The shoulder, I think, is the most straightforward of all of the joints on, what constitutes a complete examination. It's pretty clear kind of what we need to include. And it's kind of the one body part where we always pretty much do a complete exam when we're evaluating, for pain or pathology in that area. Just a couple of things, certainly there's different opinions on, whether this scan should be performed seated or lying, and there are certainly advantages to both. I personally perform almost all of my shoulder scans in folks who are lying down, but a lot of people, actually, I think probably most people do it in the seated position. And I do it just purely for ergonomics for myself and for the patient. But either way is appropriate. When you're obtaining a shoulder ultrasound or just ultrasound, in general, I think, cine loops are certainly helpful for certain things where you can kind of go back and look through, what did the transition of pathology look like. But for completely normal structures, it's very appropriate to get one good image of that structure and save a single image. So, a couple of things that does is, it forces you to really get a good image instead of, just scanning through, kind of hoping that you'll pick up what you need as you go through that cine loop. And so I'd always challenge, one thing I challenge our fellows on is, get a good image and save that single image that represents that structure. Don't just do a cine loop for everything. And so, that's just one thing I would maybe challenge you on as you do more diagnostic ultrasound. Looking at, one of the things you mentioned was the spinoglenoid notch, in the suprascapular nerve runs through the spinoglenoid notch. And you'd mentioned, fluid in there could be something that's seen with, labral tear, paralabral cyst, things like that. Also, just recognize that if you put someone in external rotation while you look at their spinoglenoid notch, that vein will dilate and it will look like there's a cyst there. So if you look at someone in external rotation versus internal rotation, if you see a change in kind of a anechoic structure, that is a vein. If you see something that's fixed with rotation, that's a cyst there. Mm-hmm. And then going on to the AC joint itself, certainly this is probably one of the understudied regions in shoulder ultrasound, and definitely an area that has some opportunity for research. A couple of things in particular, looking at the ligaments themselves. So assessing normal ligaments. Frequently when people have AC joint pathology, they have significant distension of the superior joint capsules of those coracoacromial ligaments. When you look at that distal clavicle, for most people, it sits higher than the acromion. So that's always, on your still images, there's no label of like what's medial and lateral. So, one thing is just making sure that we're labeling our images appropriately. So if other people are reviewing our images, they understand what they're looking at. But that's kind of a trick with the AC joint, is that clavicle is oftentimes slightly prominent compared to the acromion. And then when you're trying to compare distal clavicular osteolysis, to arthritis, just remember that arthritis is going to have oftentimes like some lipping osteophytes, and a lot of joint space narrowing is pretty typical as people age. And you'll see irregularities on both the acromion side and the clavicle side, where distal clavicular osteolysis should have more of that kind of, like little kind of excavations, little moth-eaten appearance to the distal clavicle itself. I think that's about all I had. I don't know if anyone else has any comments or questions, Ryan, or anyone else on the call.
Yeah, thanks, Brennan. I don't really have all that much really to add. Chris, nice job. That was well done. That was, kind of exactly what we're looking for with these presentations. Actually, most of this is just reiteration of what you said, Brennan. With the shoulder protocol, we know, for the most part, pretty much what structures we need to cover to complete or to fulfill the requirements for a complete examination. There are multiple ways to skin a cat. In other words, there are multiple ways to get through all your structures. I don't think there's any one right or wrong way. I think we all do things a bit differently. I also, similar to Brennan, will do my entire exam with them on the bed, supine, and then side lying. That's again purely out of ease for me ergonomically. I just think it's easier. But yes, a lot of folks, like Brennan mentioned, will do this seated, and again, there's no right or wrong way there. It also, and you did this, but just to reiterate this, make sure you compare side to side for the AC joint, because some folks can have some asymptomatic or non-pathologic play in their AC joint. So if you look at the literature and the papers, the anatomic variability is all over the board, right? I think a lot of us will use 2 centimeters as a normal AC joint width, but if you look at the literature, they'll reference up to 4 as normal. And so I think, assuming there's not an injury on the contralateral side, looking at the other side just to get an idea of what normal is, and then comparing side to side is important. And the other thing, like you did, is dynamic imaging. Should be part of of most of our scans, right? That's one of the hallmarks of diagnostic ultrasound, is the ability to move the patient and see what the tissues do. So, but being able to do cross-body adduction, there's also some commentary in the literature about applying kind of an AP force or an anterior posterior translation to see what that joint does. But again, comparing side to side, I think is important here. Yeah, I think that's all I have there. Yeah.
All right, thanks, Ryan. And thanks again, Chris. That was great. Once again. So the next session is scheduled for March 10th. It is unclear if we will be able to host that session or not. So please be on the lookout for the AMSSM email coming out on the kind of weekly blast on March 9th. And that will have details on whether we will have a session on March 10th or not. If we do not, you can find us again on March 24th, where we will once again be back. All right, thanks everyone. Have a great Friday and great weekend.